Hello and welcome to Module 2 of the 2014 Medical Treatment Guidelines Protocol Training. This module is designed for the EMT Basic, the EMT Enhanced, and the Advanced EMT. Once again, we recommend that you follow along with your protocol book. This training was developed by the Fauquier County Department of Fire Rescue and Emergency Management Training Division, Lieutenant Matthew Shields and Lieutenant Mary Hart. Okay, so in Module 1, we did the introduction. We told you a little bit about how to navigate the book. We told you about the scope of practice legend. That way you know where to start and stop your treatment at your specific provider level. Now we're going to break down every protocol one by one. So Protocol 1 is a very simple protocol. This is a universal patient care and initial patient contact protocol. And what this is a flowchart style of patient assessment. We all remember the patient assessment sheets from the Office of EMS as well as National Registry. This one's a little different. It breaks your patient down between trauma and medical, and even further with a trauma patient, whether or not they have a significant mechanism of injury or not. With your medical patient, it's whether or not they are unresponsive or responsive. Of course, the terminal end of this protocol always asks you to exit to the appropriate protocol. Okay, Protocol 2 is our behavioral patient restraint protocol, and of course is very important. It's a protocol that we ensure that the scene is safe, as with all incidents, but specifically with the behavioral patient. This protocol asks all providers to do a proper assessment to determine whether or not this behavioral emergency is caused by some sort of medical condition. If the patient is aggressive, violent, agitated, a threat to self or others in the setting of psychosis, for our advanced providers, if it's safe to do so, establish IV so that further care can chemically restrain this patient. And if not, if it is an excited delirium syndrome patient with paranoia, distortion, hyperaggressive activity, hallucinations, tachycardia, increased strength, and hyperthermia, of course we want to immediately physically restrain this patient. Of course, just a few things in Protocol 2. For all provider levels, we must do an appropriate assessment to ensure that this behavioral emergency is not caused by a medical condition, such as blood glucose. So we're going to check the blood sugar. We're going to gather a history, find out the causes, and if need be, physically restrain the patient. And again, for our advanced providers, if safe to do so, establish IV access. Okay, Protocol 3 is the cardiac arrest adult protocol. And in this protocol, we have something new to Fauquier County and fairly new to the medical community, and that is continuous compression CPR. You'll see that as CC-CPR. In this protocol, you are instructed to start with 200 chest compressions, insert an OPA, of course if the patient does not have a gag reflex, and apply a non-rebreather mask at 100% oxygen. Analyze the patient's rhythm with an AED and single shock without a pulse check if advised, and then continue with 200 chest compressions again and rhythm analysis again. You'll notice at the top right-hand corner of this protocol a section that says as early as possible, and we're going to cover that in just a minute. But the reason for continuous compression CPR is that us as providers, we've been focusing too much on the breathing of our patients who are in cardiac arrest. We've been focused too much, even at the advanced level, of accessing an advanced airway. In reality, that's been taking away from the important part of cardiac arrest treatment, and that is compressions. So there's a few contraindications to continuous compression CPR, and those are children under the age of 8 years old, known suspected overdose, whether or not the arrest was caused by a respiratory issue. Of course, we wouldn't want to avoid helping the patient's respiratory system if the arrest was caused by a respiratory issue, hypothermia, near drowning, and a traumatic arrest. If any of these contraindications exist, we begin standard CPR and or go to the appropriate protocol. Now, as I mentioned before, in the top right corner, the as early as possible box, for our advanced provider, well, for all providers, as early as possible, we would like to establish some sort of advanced airway. And for our EMTs and advanced providers, that would be the King airway. For our advanced providers as well, IVIO as early as possible. And as early as possible means as long as it does not interfere with continuous compressions in your cardiac arrest patient. Okay, also in Protocol 3, there are instructions on when to terminate resuscitative efforts. And if after 25 minutes of quality resuscitation efforts and there is no return of spontaneous circulation, the team leader should inform the family of the situation and consider termination of resuscitation on the scene. Of course, if you are unsure, the best course of action is to continue to treat and transport your patient to the ER and also contact medical direction. The best indicator for return of spontaneous circulation is a spike in your end-tidal CO2 readings. Cardiac arrest pediatric protocol. Now you'll notice in the top right-hand corner there's a sign that says PD, and you will see that for all pediatric-based protocols throughout this training, just so we all stay on the same page. This protocol is broken down between newborn to 31 days or less, which is a neonate, and if that is the case, then it will ask you to exit to the newborn neonatal resuscitation protocol. If the child is 1 month to 8 years old, there is no real change in the current protocols you're working under. Okay, so moving on to Protocol 5, the epistaxis or nosebleed protocol. You'll notice there's a new medication we're going to be carrying, oxymetazoline or Afrin. Within this protocol, the first question you need to ask is this nosebleed caused by significant multisystem trauma? If that is true, then we apply direct pressure and exit to the appropriate injury protocol. If the nosebleed was not caused by trauma but is actively bleeding, the first thing we want to do is compress the nostrils with direct pressure, tilt the head forward in a position of comfort, and then reassess for bleeding. If bleeding continues, this is when we get into our medications, but if the bleeding is controlled, we want to maintain that position and assess the patient for hypotension. Systolic BP less than 90, of course, age-specific is considered hypotension. So we're going to talk a little bit about Afrin. And as I said, this is a new medication. Afrin, also known as oxymetazoline, is a vasoconstrictor. It's used to control and prevent nasal bleeding. Okay, so if you've determined that Afrin is the appropriate medication for your epistaxis patient, and that is the nosebleed was not caused by trauma, and you cannot control bleeding with compressing the nostrils and tilting the head forward, then the first thing we will do is have the patient blow their nose, and we need to have suction ready to clear all of the blood and the clots from the nostrils. What we're trying to do is get to the vessels so the Afrin can have its effect on the blood vessels themselves, constricting them, slowing the bleeding, and ultimately stopping the bleeding. For the adult patient, it is 2 to 4 sprays to the bleeding nostril, and for the pediatric patient, it is 1 to 2 sprays to the bleeding nostril. A couple of things we need to consider when administering Afrin to our patients. If the BP diastolic is greater than 110, or they have known coronary artery disease, we need to avoid Afrin administration in those patients.